Hello. I did distribute one sheet of paper. It's a small quiz. I appreciate, if you could select one of the best answer. And I think one of my brother is collecting the sheets. So today's topic, I try to move around, and I just want to have show of hands. How many here are MDs, MBBS, medical diplomas? Just show of hands. Okay. Doctors, How many of you are nurses here? Excellent. Physical therapists, chiropractors, any specialty that you would like to mention that I did not mention? Medical students, okay. I just want to recognize geriatrics as an interdisciplinary medicine. That is fundamental in terms of what we practice. And I would like to kind of compose my entire talk so that every one of you understand the basic principles. And at the end of the talk, I would like to learn one or two principles that you will take home and use in your practice, and one day it may save a life. Having said that, I don't have any conflict of interest. These are all my personal opinions and from my case studies and my scientific research papers. My teaching objectives to the rest of the afternoon for the next 15 minutes is to understand the atypical nature of presentation of the disease in older people. Actually, that calling atypical, actually that's the typical manifestation, because we're seeing more and more as the way of recognition of the disease. And I want to give you a kind of approach, how do you treat these problems? And the way the medical students or nursing profession is trained is, they will tell you the chief complaint, history of present illness, past medical history, you have the physical examination, and then put all these pieces together and we'll go for a diagnostic test. Yeah, this is bingo, I have the diagnosis. That doesn't work. And then one of the key part of my talk is functional issues. Did anybody notice, I'm very proud of this Swamiji. How is his functional status? How do you say? How did you decide? What's your test or what is that?
He didn't need a PPT.
I'm sorry?
He had power by himself. He didn't need a PPT.
Okay. So it's an inner strength. Okay. So that's intellectual. But I'm asking functional, the physical functional status.
He came
Age, but age does not predict the function. There are people who are 50, probably are not able to get up from chair. How do you know?
He came running.
Okay, I think everybody has some point. Let me tell you, when Pope John Paul visited New York, I had the opportunity to speak to the geriatrician from Mount Sinai, New York. They specifically invited this geriatrician to understand Pope John Paul II physical strength. He had a tremor, he was kyphotic, they were suspecting Parkinson's disease. So this is his first visit to United States, and this geriatrician was brought to the New York Kennedy Airport. When he is getting out of the flight, he was examining his gait. So I have this reflection back when Swamiji, when he entered the podium, he was running almost. When he is getting out, he's not walking, his gait pattern. So watch your journals. In couple of years, there will be another vital sign for older people, that will be gait speed. Stephanie Studensky at the University of Pittsburgh, she has published the way the older people walk, the gait speed, get up and go, will become one of the best functional status that you could measure. So kind of observation. So I'm going to tell you something about the functional status that you probably feel you paid well for this conference. You don't regret. Now, this is the kind of competency. Competency is defined by Accreditation Council for Graduate Medical Education. How do you measure a person's competency? This is a competent doctor. This is the definition. I tell you, I brought this definition to your attention because to be a competent geriatrician, you probably need these skills. It's a habitual, and I met this gentleman who defined Ron Epstein, who wrote this definition in New England Journal. So competency in medicine is habitual and judicious use of knowledge. I'll come all those features. Knowledge, clinical reasoning, values, emotion, reflection, technical skills to the benefit of the person or to the community. So that is that kind of approach you need taking care of older people. Can you believe the emotion of the clinician plays a role? And this is being defined, and they are measuring, how emotionally you are mature in terms of what you're delivering to the patient care. That's very important in terms of taking care of the older people. So I told you about atypical. I have 50 slides. If I show you all the slides, I have to flip within 3 to 4 seconds each one. But I'm going to show you very important slides that are very helpful. Now, this is kind of tell you in terms of the functional decline on admission have independent impacts on adverse hospital outcomes. That's why when the person is checking into the hospital, what is his status actually is a predictor of his outcome. And I just want to make sure, atypical, we know several diseases manifest like that, but I'm going to give you principles so you could use it to any disease that you come across with the older person. So for example, when a person with pneumonia is admitted, you usually don't see the cough, sputum production, shortness of breath. Whereas in older people, it may manifest as malaise, anorexia, and confusion. And myocardial infarction, mild chest pain or none, it may manifest as dizziness or syncope. Urinary tract infection, no dysuria or frequency or hematuria. In thyrotoxicosis, lethargy, cardiac arrhythmia, fatigue, loss of weight. Appendicitis, there will be a whole diffuse abdominal pain rather than classical right or left quadrant pain. Confusion, urinary urgency, and there may not be leukocytosis in the infection when they manifest. In depression, confusion, apathy, absence of subjective feelings of depression. I'm not going to give you a cookbook, this is the way atypical, because that may or may not work statistically. So this is another reason why the older people are different, because they carry more than one disease to their belt. And we never know how these two diseases will interact, particularly when you use several drugs, because you need to look into the effects of drugs too. Now, this is kind of astonishing fact. Oops, sorry. Okay, this is the survey, I gave it to you. This actually predicts how you kind of understand your own emotions or your own biases, and this will determine what you do at the bedside. Can anybody volunteer to pick up one of the best answers? The question is, who has more negative attitude or bias towards older people? Anybody would like to stand up and speak? I want Anu not to, I just want to recognize Anu, who came all the way from Boston, and she did the fellowship in the same medical school, a hospital and a Harvard program. Anu, would you like to stand up? Okay, I excuse you not to answer because you may know the answer. Doctors? Younger generation? Younger? What did you say? Younger generation. Who is that? Come here. Maybe you could catch it on. Come on. Okay.
Better continue with questions.
Okay. You are right. Older people are more prejudiced, negative attitudes towards their own people. This shocked me when I first joined the geriatrics program. I was trying to find out who has more negative attitude. I tell you a small story, hope my time permits. So I gave a talk to a group of doctors and I did the survey and I asked the same questions and I was discussing why older people. And one of the nurse who was in the audience came to me and said, Dr. Manghdhara, you are right. We have this 85-year-old gentleman, one of our neighbor, whom we are talking. They live in New England area, which is very cold and unpredictable weather. Maybe you should move to Florida, which is a very sunny state where a lot of older people are moving. This 85-year-old gentleman told to the nurse, there are too many older people there. Can you believe that? An older gentleman telling he's uncomfortable being in a place where people are moving. So that why I am saying this one, this predicts how you approach. And I did this small study at the Hyderabad Management Association. There are 100 people, one gentleman in the audience, and this is very important for your policy. One gentleman said, the federal government, central government has bias towards older people. I was shocked. I said, can you explain to me? Well, they want the people to retire at the particular, just because of the age you have to retire is considered bias on one single parameter of age. This is clearly described in literature as ageism, no different than racism, sexism, anti-Semitism. And when I interview candidates for the geriatric program, I ask them, why are you choosing this field? And most of them say, you know, I like my grandpa. I was among older people, they're very nice people. They tell me stories, you know, all these kind of. So there is some kind of likeliness to these people that predicts that this doctor will do well and really advocate for these older people. Now, this is very important fact. Why the geriatric patients manifest disease atypically? See, one of the reasons is they carry so much burden, disease burden, and frequent occurrence of comorbidities, 65 and above, 50% have 2 or more diseases. And this is the single most problem. Because of the cognitive impairment, their diseases are manifested differently. That the master gland or master organ of the body is very important. And I tell you, in terms of the functional improvement, we need to preserve this capacity too.
Sir, last minute.
No, we started a little late. No, we didn't start at exactly the same. I counted exactly the time that will be past 45. Now,
Yeah, okay.
so one of the things that the older people manifest disease is there is something called Claude Bernard's homeostasis, which is what happens is whenever there is a stress on the body, there is a way of adjustment, which is homeostasis. You know, when the outside temperature is higher, usually older people manifest differently compared to younger people. You sweat, you feel like drinking more water, you conserve the water by not going to the bathroom. The body preserves, by anti-diuretic hormone. Whereas in older people, they continue sweat, they continue manufacture the same amount of urine, they don't feel like drinking. So this is another factor that the principle that will help you to understand better in terms of. Now, having said that, I just want to flip the ADLs and activities of daily living and instrumental activities of daily living. This is very important to know, and I will corroborate with the functional status. And let me flip to the. Yeah, I think I heard some of the speakers say, as we are aging, everything falling. That is not true. That is not true. That is a myth. Actually, some things get better. The hormone levels same, liver enzymes, electrolytes, body temperature, basal glucose same. No age-related anemia. Actually, there's only few things that changes as we age. So let me give you a principle why they manifest different is there is a principle called weak organ link, which I'm going to show you. These are the changes that happens in each system, which I'm not elaborating. This is the gist of the talk of the atypical presentation. If you learn that there are 3 weak link organs in older people, you will understand the disease manifestation: brain, bladder, and muscle. When a person gets a disease, example is pneumonia, he may be brought to the emergency room with a fall, with a change in mental status, incontinence. And the disease is not in those 3 organs. CAT scans 99% negative. You will call the urologist, nothing wrong with the bladder. Suddenly, overnight, the prostate did not grow bigger. And there is nothing wrong happened in the muscle. The reason is the problem is outside the bladder. So think in these terms of weak link, you will be able to figure it out, the problem. Now, functional status. And I just want to give you, and I didn't talk to you about the delirium here is another big topic. Okay, this is the principle. When people are talking about extending the lifespan, but let me tell you, in our lifetime, we probably should concentrate on improving the function, which is practical, everyday problem. Maria Fiertron, Tufts University, 90-plus-year-old at the Hebrew Rehab, they did this function. Now, has anybody ever saw these things before? And I just want to ask you, each one of you kind of, anybody see these before? Okay, who used it this morning? How many people used this morning? 1, 2, 3, 4. Okay. Okay. How many advised your patients to use it? 1, 2. We need to study some geriatrics here. Let me tell you, Maria Fiertron took the CAT scan images of the biceps muscle, thigh, just for a couple of weeks doing these exercises, took the pictures after 4 to 5 weeks, they hypertrophied. So actually it was in BBC and everywhere that age can be reversed. So you could improve the sarcopenia, the muscle fibers. So this is very important. Now, all my patient does this. People reaching something in the cabinet, they fall because they don't have this grip. So this will improve a lot upper body. Now, as I'm going to conclude in a second, falls, it was mentioned in Swamiji lecture too. that it's the landing principle that's very important. I have a patient who fell 40 or 50 times 1 year, but never got injury. And I said, let me ask you, what's your secret? Doc, I land like an eagle. He has that awareness of that fall. So now, I just want you to take home my principle, which is Madineedi principle, is if I sit up and if I can't get up on my own, I think we need to promise to ourselves, if I can't get up like this on my own, what kind of bodies we have? Take this as a serious thing. Get up and go. It was a $5 million NIH grant. Why people cannot get up and go. The core muscles weak and quads were weak. And that's the one thing, if you could practice at the bedside to your patients, you are doing a remarkable job. I just want to show you one more slide, which I recently incorporated.
Thank you.
There are Bruce Ellis at the University of Arizona. He studied why certain plants were resilient and why others are kind of perishing. Orchids and dandelions. What he found was we have the same nature in aging too. There are frail older people,
Okay.
and my brother who helped me travel all the way here. Thank you.
Since the lecture is so picturesque, we don't allow any more questions. Thank you.
Thank you, sir. May I request Dr. Amit Arora and Dr. Anup Amarnath to honor Dr. Manghdhara, Assistant Professor of Medicine, Harvard Medical School. Thank you so much, sir.
Thank you. Thank you.
Let's give Dr. Manghdhara a big round of applause. Thank you once again.
Thank you. Thank you for giving me.